Good morning. Thanks for being here voluntarily. I assume everybody in this room either picks up blood, hangs blood, charts blood, make sure the blood gets back to the blood bank. A nod, maybe. All right. My name is Lance Torella. I recently joined Erlanger. I spent about 12 years at Mayo Clinic in different roles, from cardiac surgery to the ICU, and most recently as an educator. So I'm glad to be here and looking to hopefully improve your process for getting blood, charting blood. We'll be doing a lot of different things over the year to hopefully improve the process, most importantly improve the safety for our patients. You all should have received the new pickup, not necessarily a new pickup ticket, but a revised pickup ticket that is being requested that is used. We've seen a lot of different varieties of papers that come down for blood to get picked up, and we want to streamline the process to make sure we're getting the right paperwork. I have a few slides I'm going to go through, and then we'll walk through the pickup ticket. So PBM, also known as patient blood management, we know blood is a precious resource. It is limited, even though blood assurance, we can see it from our window. Oftentimes we underestimate the cost of a transfusion. A unit of red cells cost over $1,000. Even though we give it free, the hospital gets charged close to that by the time you figure in the tubing, year time, the product that's wasted, $12,000 last week. In addition, we underestimate the short and long-term risk. The latest evidence really shows a lower threshold of a hemoglobin of 7 unless a patient is actively bleeding. And then oftentimes we overestimate the true benefit to our patient. So some of the things that you might be aware about are the infectious complications. The blood bank, blood center does a great job of identifying those: Babesia, chikungunya, dengue, malaria, and most recently Zika. Some of the more common ones is bacterial contamination of platelets. Almost 1 in 3,000 units of platelets are contaminated. So it's a bad outcome there. Anaphylactic reactions as low as 1 in 20,000. And this last one here that we can truly have an impact on is clerical error, hemolytic transfusion reactions, so giving the wrong blood to the wrong patient. Some of the more latest evidence is around TRIM, transfusion-related immune modulation. So what happens to cancer patients that get blood? What type of antibodies are in the blood that we're giving them? Are they having a higher reoccurrence? We do know that patients that get blood products during surgery, they increase their likelihood of an infection after surgery. Pulmonary complications, TACO, transfusion-associated circulatory overload, TRALI, transfusion-related acute lung injury, which is more prevalent patients that get FFP. And this last one here, the storage lesion. What happens to blood after it's been sitting in a bag for up to 42 days? There's a video that I could show, but it's interesting what really happens to the cells. So your favorite Typenex band, everybody like these? You're lying. Unfortunately, our process right now is 2 armbands. Over the next year, I want to see that armband go away, and hopefully you guys will be happy about that. I'm sure none of you have ever cut one off and attached it somewhere to the patient, but not around the wrist. When that does happen, there's a process of getting a new armband on the patient. It's not very straightforward and requires a whole new sample being drawn, so we're working on ways to allow us to be able to reattach that. Does everyone know how to use these? I assume so. So the biggest thing is making sure that the blood bank gets this side if you are doing a type and screen or a type and cross, and then every time you send a tube that they get those labels on them. So the blood pickup ticket, you guys should all have one in front of you. So the idea is that we're going to know who the patient is. We're also going to have that sticker that's on the blood bank armband. If it's MTP, just let us know what cycle it is. And if it's not an MTP, making sure whoever's coming to pick up the blood, we know what products they need. And what the other important part of this is if it's in a cooler, making sure that cooler gets back. We are going to place responsibility when that cooler gets in the room to the circulator. Since I've been here in about 5 weeks, we've thrown away about $33,000 in blood products. Not only is it a cost, but we're also wasting somebody's donation, and definitely something that is preventable. So in addition, the thing that we added is the ordering provider. We are going to be looking at provider blood usage to hopefully see who's maybe over transfusing, who's maybe holding blood inappropriately, and making sure people are getting the products they need when they need them. And the bottom one, everyone in this room should have a lab or a blood number. If somebody comes down and doesn't have that, technically they can't get blood. They need to be trained in the process. If you have people in the room that aren't trained, let us know and we'll make sure that they get the training. If we were audited and somebody doesn't have a blood number or they're using somebody else's number, we could be held in violation for that. So what did we actually see? And this was yesterday. I think I saw 2 or 3 gown tags. They're great that we reuse stuff, but no more blood tags, no more paper towels, note cards. They're all things that are convenient. It has most of the patient's information on it, but it doesn't have everything we need. And the issue there becomes consistency and making sure that we're following an SOP in the lab, just as you guys do in the OR. Has everyone done a variation of this? This is the time to come clean. So hopefully we'll make the process better. Over the next year, I have lofty goals of potentially using Epic if we can get the process more streamlined. The issue Joint Commission would have with even these tags is not having an order in the chart. But we haven't had to cross that bridge yet, so I'm not going to open up that can of worms. So a blood transfusion is a tissue transplant. I think if we looked at it as we do any type of transplant, whether heart, liver, kidneys, lungs, I think we might take a step back and really think about what we're giving to this patient that we potentially could kill them if we give them the wrong product. So that's why the folks in the blood bank, they might give you a hard time, but they really want to make sure that that patient is getting the correct product. They're not doing it to be mean or slow your process down. They don't want you to hurt a patient. They don't want to be the one responsible that gave you that product. So blood coolers, you guys have seen these in the OR in a corner underneath the blanket, anywhere in the OR, I am sure. We have 2 different versions right now, or 3 different versions, but 2 different time frames. These 2 on the left here are only good for 4 hours. Do we have any cardiac folks in the room? So our cardiac cooler is the more expensive one. It's almost as good as a Yeti, is good for up to 12 hours. The issue that we do have with both of these is getting them back in a timely fashion. Once your patient leaves the OR, the unit doesn't need this blood unless they're actively bleeding. don't send it up there with them, because then we lose track of where that blood is. And if we try tracking it down, we call down here, somebody probably has no clue where that cooler is. So we do ask that once the patient leaves the OR, that you bring that cooler back. Hopefully we can prevent any loss of product.
Well, now sometimes anesthesia requests
That it goes up.
Anesthesiologist requests that we take that blood up. And
So-
I can't override an
Right.
anesthesiologist.
So we'll be chatting with them as well. And if that patient isn't actively bleeding, do they truly need that product? And if they are actively bleeding, should they be leaving the OR? So, yep. So, and I think that's probably where most of it.
As long as you're going to talk with anesthesia.
Yeah,
But I don't want to be the one that says, hey.
Yep. I'll give you guys my number as well. 4230. So we're not trying to prevent people from getting products they need. We want the right patients to get the right product. We don't want to be throwing away $30,000 a month. I'm sure we could use that in other places. The other thing we're going to do with the coolers is to make sure that they get returned in a timely fashion. Is you guys have had kitchen timers that are very loud. We're going to affix some type of timer to the handle or possibly to the side. We'll set the timer when it leaves the OR or leaves the blood bank, and within 4 hours, or we'll probably do it at 3.5 to remind you to get that cooler back to the blood bank. And it won't turn itself off. You'll physically have to go over and turn it off. It is loud. You might hear it in the hallway. So if you do leave the room and forget about it, that's going to be my holdover until we can get some type of RFID tracking, where we would have a board in the blood bank. We would know where that cooler is, and then we could call the appropriate areas. Want to show one short little video why I'm so passionate about making sure blood products are used safely, that we're not letting them sit and being transfused. There might be sound here. If there's not, I will focus through it.
2 months is too little. They let him go. They had no sudden healing.
So this was an 8-year-old girl that received, or that had cancer, had chemo radiation. She had a low platelet count. Her doctor had her come in for a routine platelet transfusion. Fortunately, she received contaminated platelets. The day before, in a nearby transfusion center, they had that same donor platelets that were contaminated. The nurse stopped the transfusion but never alerted the blood bank. If she would have alerted the blood bank, they would have pulled that remaining product off the shelf and would have prevented this 8-year-old girl's death. So we're not trying to be hard or mean about things, but we're here to help people, not make people worse. Not to end on a bad note, but I definitely want to see us do what's best for our patients. And if you guys ever do have a patient that has a reaction, make sure the blood bank knows about it, so we can alert blood assurance that, you know what, especially with all of the cryo increase that I've seen over the last year, cryo is a pooled product. Sometimes can be over up to 10 different donors. So 10 people are getting, or one person's getting exposed to 10 different people. So there's that potential of things that could prevent. So just ask your guys' diligence if you ever see any type of reaction, or if the bag just doesn't look right, give us a call. Don't hang it. We'll get you another one. And I am looking forward to seeing all blood bank tickets come down with these. I believe Ashley has printed out enough for each OR. We are going to have them on a smaller, about half sheet of paper that'll be in each OR. And if you guys need more, let us know. We can get them more printed. Any questions, concerns?
How do the platelets get contaminated?
So it can either be in the collection process. So when the skin's being cleaned, when that needle's being inserted, there's potential for contamination. The other thing with platelets, they're stored at room temperature. Anything stored at room temperature, there's that potential for bacteria to grow. And platelets are only good for 5 days. Since this incident, they institute a solution called Virax that does help to eliminate most bacteria that will grow, but they also extend the shelf life to 7 days.
Okay, why is one of the bands going away?
Not yet. That's my goal. So,
Why is that your goal?
because when you add,
Sometimes more is better.
sometimes more is better, but also
More
if
information is better for safety.
so, what we would be doing is we would be using a barcode scanner. So we would barcode that patient's armband and barcode that blood bank. So for almost 15 years at Mayo, we were using just one. We did over 3,000 cardiac surgery cases a year. We had probably about 5 times the amount of volume in blood transfusions with 0. So it does work. And I've been in about 20 different hospitals consulting, and very few still use the 2 armbands. So it is proven that it does work. You're eliminating that more information, but when you also add more information, more chance for errors, because then you also have to have that separate tube. Technically, we should be drawing 2 samples on a cross match or a type and screen on the first transfusion if we would want to theoretically comply with ABB and CAP and the guidelines of the Joint Commission. So hopefully we can eliminate one of those and be in compliance. And someday, hopefully, once we cut our blood usage, you might also see the remote dispensers for blood. So you walk up with your badge, you walk up with a patient sticker, and it spits out your blood. Takes about 60 seconds, and you no longer have to talk to somebody in the blood bank unless that patient will have antibodies. That would be red cells only. That's my 2 to 3 year goal. Thank you.